Hello, my name is Dr. Melissa O'Neill. I am a clinical faculty member in the School of Counselor Education. I am also an Adams State grad, having completed my PhD in counselor education um, with Adams. So I am really excited to be here talking with you all about eating disorders and diet culture mentality, and how that relates to higher education. So, additionally, a little bit about me and my background. I am a certified eating disorder specialist, and I am an IADEP, which is the International Association of Eating Disorders Professionals, approved supervisor for certified eating disorder specialists. I am a licensed professional counselor, as well as have my certificate in clinical military counseling. I have worked in higher levels of care as well, so like treatment center settings, as well as outpatient treatment for eating disorders for the past decade. And this is really where clinically where my passion lies, and where my advocacy heart is. So again, really thrilled to be sharing this information with you all. And my hope is that there is a helpful impact on campus. I also, before I start this presentation, we are talking about diet culture and eating disorders. And I think it's really important to state and acknowledge my identities and some of the inherent privileges in my identities. So I identify as a white cis hetero female, and I also present in a thin presenting body. And while I also have lived experience of having had an eating disorder, I also have been recovered for over a decade. And so I think it's important when we are talking about specifically these issues related to bodies, to the way that we perceive bodies, to eating disorders, diet culture, et cetera, that we both acknowledge our identities and our perspectives and perceptions of these issues, as well as the inherent privilege and minoritization and oppressions that people who in differently presenting bodies experience. So we can't possibly always get it right, and I think we're all learning together. So with that being said, there's a little bit about me, and let's dive in. So our learning objectives for today are to define and discuss what diet culture and diet culture mentality is, to discuss risk factors and prevalence of eating disorders, and to identify ways to broach concerns about eating disorders or disordered eating with students. Over the last couple of weeks, there's been a lot of excitement in the field of eating disorders specifically, and advocacy, and also the field of size inclusion and weight stigma, weight bias, about this article that was just published in the New York Times. And truly, it does feel like, at least in my bubble, the New York Times article that everyone is talking about. And what these brave individuals did was to identify and discuss more specifically and through lived experience, atypical anorexia. And so historically, we have a pretty solid understanding of what anorexia nervosa is. And that is sort of the poster child, so to speak, of eating disorders. So generally, when we conceptualize somebody who is experiencing an eating disorder, what do we picture? Generally, we picture a younger, white, cis hetero female, generally from an affluent background, and who has the resources and the means to access care. And we conceptualize this as more of a social illness or a social disorder rather than genetic, biological, environmental, etc. So when we talk about atypical anorexia, which is a newer diagnosis, this is somebody who is living in a larger body, who is experiencing the exact same symptoms, behaviors, thoughts as somebody with what's considered kind of classic anorexia nervosa. The only difference is that they are living in a larger body. They very much could be and have experienced precipitous weight loss, and very much are experiencing distress. Their body is under duress. They're experiencing medical complications. They're experiencing the same amount of intrusive thoughts that somebody with this more classic presentation is, with the caveat that their eating disorder, because they live in a larger body, their eating disorder is encouraged. This aligns with diet culture and diet culture mentality. And so, I mean, what do we do if somebody loses, if somebody is living in a larger body and loses a large amount of weight? We clap, we cheer, we celebrate them, and we don't ask any further questions. The clapping, the cheering is a part of diet culture and diet culture mentality that we're experiencing in our culture. And we're not asking, we might ask, oh, how did you do that? Did you, are you going to the gym? Did you change your diet plan? What diet are you on? And we are then encouraging diet culture to persist. We're actually perpetuating it, and we are perpetuating the eating disorder for that individual. We are reinforcing that individual's eating disorder, and this is deadly. So if you have the opportunity to read this article, it's phenomenal, and it provides an excellent picture of what it looks like to live with atypical anorexia. So we're going to get into a little bit more about diet culture mentality, and talk a whole lot about some of these other aspects of that are related to this article in particular. So first off, I'd like to talk about the basics that we need to know about eating disorders. This is kind of our Eating Disorders 101, and I actually have the great honor of teaching Adams State's, I believe, first ever elective course, at least in the School of Counselor Education, elective course on eating disorders. And so I've been able to pull a lot of information together and share that with some of our counseling students. And it's fascinating and so rewarding for me on this end to be experiencing this information through their eyes and through the lens of a counselor in training. So, eating disorders are complex mental illnesses impacting an individual's relationship with food and body image. This also might impact their relationship with exercise, as well as their world, their environment. What we know is that typically eating disorders, the representation of eating disorders include approximately 2/3 women, approximately 1/3 men. And the total amount of people experiencing or having a lifetime experience of an eating disorder, or a lifetime incidence of eating disorders, is approximately 30 million. So there are a couple of issues with these statistics. One, 30 million in my estimation, and by estimation of quite a few experts in the field, is kind of where it is an underrepresentation of how many people are experiencing eating disorders. And we're seeing this number on the rise, not necessarily because incidence of eating disorders has increased, but it's because the acknowledgement of eating disorders and providing access to care and providing access to preventative resources and better screening tools and better knowledge and understanding is increasing. The other issue with this statistic is the inherent binary statistic of women and men only represented in this 30 million. And what we know is that there is greater risk for folks in the LGBTQIA plus community. However, there is still a significant lack of research and resources to support this. What we know also is, what we can kind of deduce is that 2/3 of these folks are assigned female at birth, 1/3 are assigned male at birth. And so we really need to do a better job of re-identifying these statistics and kind of recalculating our knowledge base. In addition, we need to talk about eating disorders versus disordered eating and define the two. So eating disorders, the difference essentially is that if somebody is experiencing an eating disorder, that eating disorder is having a marked interaction with their daily life, and it's providing, or it's causing marked distress. So they might be experiencing some severe medical complications. They might be experiencing social isolation, distress in terms of racing thoughts, not being able to turn off thoughts about food, body image, constantly body checking, constantly looking in the mirror. And this is a severe disruption to their lives. Somebody who's experiencing disordered eating, or what I kind of consider subclinical eating disorders, that honestly is probably most people in Western culture, because we are so influenced by diet culture. And so disordered eating might be representative of it could be representative of an unhealthy relationship with food, an unhealthy relationship with somebody's body and body image. And so that could manifest in engaging in diets or being a yo-yo dieter. That could be trying out different exercise routines or regimens and maybe pushing a little bit too hard, but not to the degree that we're kind of tipping into a clinical eating disorder. There is certainly disruption and distress that occurs in disordered eating. And there's also a lot of social acceptance and encouragement to continue these disordered eating practices. And we see the health and beauty and diet industries being worth billions of dollars, and they're constantly selling us all the things to be more beautiful, to be more thin, more trim, more fit, more this, and not acknowledging that we have inherited genetics and the neurobiology that is ours exclusively. And there is a shift happening, this beautiful shift that's happening, that is actually embracing and accepting of lots of different sizes and shapes and abilities and disabilities in body presentations. And so we're seeing that. And I had an assignment for my students to find an image that promoted either a positive or a neutral, like a more positive body image in media, and they found just the most beautiful depictions of size inclusivity, of body inclusivity, and so we're seeing that shift happen, and seeing people are able to see a body that looks like theirs represented on TV or in a magazine or online, rather than this traditional thin presenting kind of quote unquote body ideal that very few of us is able to achieve, essentially. Okay, so what we also know is that approximately 3/4 of individuals experiencing eating disorders will not seek treatment of any kind. So they're going to live with this and generally live in private with this for their entire lives, maybe. And this is an issue. Access to care is a big issue. This is also where this concept of not being sick enough begins. And this is this interaction of social comparison and disordered eating, eating disorders, body image distress. And, we could point out, well, that person, the way that their body is presenting, or their eating disorder is further along, they're sicker than I am. I'm not sick enough. I don't need that kind of care. Nobody has acknowledged this in me, or I went to see my doctor, or I talked to my nurse practitioner, and they didn't seem to have any issues with what I was doing. I'm not sick enough. And that is inherently harmful to the individual and to our culture. In addition, just starting out here, I do want to acknowledge that this infographic here and show, I think the National Eating Disorders Collaboration did an exceptional job of showing the difference in eating disorders diagnoses and the prevalence of eating disorders diagnoses. So as you can see, the majority of people experiencing eating disorders are experiencing binge eating disorder. Now, this is a drastic contrast to what we historically, classically view as somebody who is experiencing an eating disorder having anorexia nervosa. Those experiencing other specified feeding and eating disorders, avoidant restrictive food intake disorder, or unspecified feeding and eating disorder represent this green category of other eating disorders. So these two categories alone represent the majority of people experiencing eating disorders. So think about that for a second. Think about what we believe eating disorders are and the amount of and how that's represented, and then think about what eating disorders actually are here represented through this pie chart. Anorexia nervosa represents the smallest amount of individuals experiencing eating disorders, not to downplay the severity or the need for care. This is just a representation of the population of individuals experiencing eating disorders. And bulimia nervosa is the second smallest category. And this is probably the second most considered eating disorder of somebody who is kind of the classic presentation of somebody with bulimia nervosa is somebody who is binging and using a compensatory behavior like purging through vomiting, laxative use, diuretics, excessive exercise. Okay, moving on. Common risk factors, so things to look for somebody who's experiencing an eating disorder or kind of on the precipice of developing an eating disorder, include, of course, changes in eating behaviors. So this might be somebody has started a new diet. Maybe they've decided to go keto. Maybe they have decided to begin intermittent fasting, or they might be combining diets. So maybe they have self-diagnosed that they're experiencing that they have a gluten sensitivity, so they're going to cut out gluten. And why don't we just cut out all carbohydrates anyway? Because I've heard that those might, this is kind of coming from that diet mentality, because I've heard that maybe those are bad for me. So I'm just going to cut those out. While I'm at it, I'm going to cut out sugar. So automatically we have some significant reductions in food groups. Also, this is somebody who might be experiencing a preoccupation or an obsession with food, with calorie counting, caloric content, nutrition value, or the idea of nutritional value in a food. This also could be, instead of dieting, this could be an increase in intake in food. In addition, another risk factor is body image distress. So somebody who's constantly body checking is checking parts of their body, looking in the mirror, making so this can relate to body dysmorphic disorder, which is a it's a severe distortion in the way that we perceive our bodies. And so somebody who's experiencing body dysmorphic disorder looks in the mirror, and what they see is not how they actually look. They might see, they might look in the mirror and their nose looks 10 times bigger than it actually is. Or they might see wider hips, or they might see bigger legs than they actually have. And this can cause severe disruption and distress. This can cause somebody who might have experienced anxiety, for their social anxiety to go through the roof. They might be experiencing increased or decreased activity levels. So they might start to go to the gym a lot more frequently. They might be spending more time at the gym, or they are completely limiting, decreasing activity, or kind of somewhere in between. Like I've said, social isolation. This is one of the biggest ones. Eating disorders thrive in isolation, and so that social isolation is compiled into the eating disorder presentation. And becomes an aspect of it that perpetuates the eating disorder. There's a lot of inherent shame that happens. And so a lot of that avoidance of other people, reluctance to engage in social activities is part of the eating disorder. They might experience mood swings, changes in affect or regulation. They might be predisposed to be perfectionistic. They might demonstrate impulsive behaviors, or being explosive or a little bit more erratic. And then, of course, as I had mentioned, genetics and neurobiology. And there's a really interesting group of folks who are exploring the neurobiology of eating disorders. Dr. Laura Hill is one of the primary researchers who's doing this work. It's fascinating, and really, truly identifying that one of the main factors underpinning the development of an eating disorder is just how our brains are wired. And so it's not necessarily this social illness or social disorder. What their argument is it's truly neurobiological. Okay, moving into the insidious diet culture and diet culture mentality. And I say insidious because diet culture and its mentality has caused such a great amount of harm in our culture. And I see it. I was just on campus this last week for our fall labs experience, and I hear it all over the place. I hear people commenting on other people's bodies. I hear people being concerned about the way that their body looks, or how clothes are fitting on them. It's everywhere. It's all around us. So we need to start to kind of perk up our ears to what it sounds like and start to flip the script. So what is diet culture? Clinician Tiffany Rowe, who is also a mental health advocate and an eating disorders specialist and an advocate, created this excellent graphic to define what diet culture is. So it's a system of beliefs that values weight, size, and shape over health and well-being. And some of you might be thinking, well, no, that's interesting, because it's the lower your body weight, or, within a normal BMI maybe, or a normal ideal body weight, then you're supposed to be healthy. There is not enough research that tells us that weight, size, and shape equals health. In fact, diet culture tells us that low body weight, or sort of this, again, normal BMI, and I put hard air quotes on BMI, that's a whole other presentation, because the BMI is not only outdated, but not a helpful tool for measuring an individual's healthy body weight range. But okay, so a quote unquote normal or lower body weight equals healthy. A higher body weight equals unhealthy, according to diet culture. Culture also promotes weight loss as a means of attaining higher status. And so think about the actor Jonah Hill. And he has undergone a significant amount of scrutiny for his body size and presentation. And also think about the singer Adele, same thing. So the idea of Jonah Hill lost a certain amount of weight and all of a sudden his body fit into more of this thin ideal that we experience in diet culture, all of a sudden he was getting a lot of praise. He wasn't getting as much scrutiny on how his body presented. And all of a sudden he was this revered person who did this great thing of modifying his body for supposedly the public's benefit, when that was his body, his choice. And he's been very, very vocal about the fact that it's nobody's business how his body looks. And I appreciate and applaud his bravery in that. Diet culture also worships thinness and says thinness and health is health and moral virtue. So this idea that somebody who lives in a thin body is better than, somebody who lives in a larger body is less than. And we see that all over the place. We also, if we live in a larger body, might experience that as an implicit bias and have internalized fat shame, internalized anti-fat bias that tells us we are not worthy, we are not good, our body is not good because we live in a larger body. And then the opposite, according to diet culture, the opposite is true of if we live in a thinner body, we have the privilege of not having to worry about that. We also might live in fear of, if we no longer live in a thinner body, what could happen to us, the ramifications that could happen to us socially. Diet culture demonizes certain ways of eating and elevates others. So the idea of intuitive eating, which was developed by Tribole and Resch, and it is an entire concept that embraces listening to our hunger and fullness cues and honoring our body with the foods that we need, the foods that we desire, and the foods that are going to both fuel and nourish our not only our bodies, but like in allowing us to enjoy food. And diet culture says, no, you can't eat too much of this, or you need to eat less of that, or you need to eat these certain foods, or eat 5 greens and 2 reds and a purple and a yellow. And there are all sorts of ideas that are either restrictive or avoidant of certain food types. And so there are certain things that are okay and certain things that are absolutely not okay within diet culture. Diet culture also says to shrink yourself by any means and encourages disordered eating. So I've talked about this a little bit in terms of what this is saying to people, especially people who live in larger bodies. By all means necessary, diet culture says, change your body. And then finally, diet culture oppresses people who don't match up with supposed picture of health. In terms of health, diet culture makes a lot of presumptions, and almost like we are supposed to, we have the right to comment on other people's body. We have the right to comment on other people's health status, and we should be able to see somebody's health status based on the presentation of their body, which is not true. There's no way of knowing whether somebody is healthy based on how they look. And a great example of that is if we are using under the umbrella of diet culture, if we are demonizing a person who lives in a larger body and telling them, you're at risk for developing diabetes, you're at risk for high blood pressure, you're at risk for X, Y, and Z. And then somebody who lives but they are not experiencing any of that. Their labs are stable. They've gone to a physician who is size inclusive, and they have essentially a clean bill of health. Whereas we have somebody who is in a thin presenting body, and they might have a terminal illness, or something that is below the surface that we can't see. Diet culture tells us, well, the person who's thin is healthier than the person who is larger. So do you see the difference that we can't make those assumptions based on a person's presentation? But diet culture is really trying to tell us to do that. So moving on. Here is what diet culture looks like and sounds like. And this is taken from that New York Times article. It's called "You Don't Look Anorexic." So it says, this is one of the individual's lived experiences. As she grew older, people at the gym clapped and cheered for her while she worked out. People would say, "Go, you can lose the weight." She says, while eating in public, other diners offered feedback and still do to this day on her choices. A few even asking if she wanted to join the gym. Some would call her names, pig, fatty. Sometimes people told her she was brave for wearing shorts, while others said she should cover up. She was always aware, whether she wanted to be or not, of how others viewed her body. So along with diet culture and diet culture mentality come our implicit biases. This includes anti-fat bias, and I've alluded to anti-fat bias already. And a good friend and colleague of mine actually did a guest lecture for my course this semester and talked about these implicit biases, and in particular this anti-fat bias. It is the belief that people in larger bodies are inherently unhealthy, lazy, unintelligent, or that they want to be thin, and that's something that they're constantly working toward. These are all biases and beliefs that are inaccurate and overtly harmful to the individual. They're also overtly harmful to our culture. And people in larger bodies experience oppression every single day. They, up until recently, have never seen a body in media representative of their body. They might go into a classroom and not be able to find a place to sit because there isn't a chair or a bench that supports them properly. They might go into a doctor's office and experience the same thing. They might receive lots of negative attention or get those unsolicited comments, like the last example that I provided, if they're in the dining hall and they're picking out foods that they're going to eat. And there's nothing more shaming. There's nothing more shaming than commenting on somebody else's body like that. And truly, it's none of our business. There should be no link to a person's inherent value and the way that their body presents. In addition, these negative assumptions, stereotypes about people's bodies are a part of our implicit biases, and also a part of this anti-fat bias. So as I had mentioned before, as we consider what comes to mind about what we believe someone with an eating disorder looks like, that is an implicit bias. And what is interesting about the research is that folks in larger bodies are 2 times as likely to engage in disordered eating, but only half as likely to be diagnosed with an eating disorder. That disordered eating is that diet mentality, that diet culture of, maybe they were 8 years old and they went on their first diet, like me. And they thought that if they could just, here's me speaking in if I could just change the way that my body looked, I could be more accepted. People would be okay with that. And that's where this childhood experience of maybe their parents are encouraging them to go to Weight Watchers with them. Maybe their parents are restricting intake. And we can get in that cycle very quickly about, well, that those parents are doing a lot of harm, and that's we need to demonize. Now we're gonna move the demonization, is that a word? From the individual to the parents. Well, the parents are the problem. The parents are bad. No. The parents, that a lot of those behaviors are born from their own wounds. Maybe the parent has lived in a larger body and has experienced the same types of oppression that their child has started to experience living in a larger body, and they want to protect them. They know that diet culture and diet culture mentality is harmful and painful, and they want to protect their child from that. How scary is that? And so we do things and we say things that are counterintuitive. What's so beautiful about our world now is that we are shifting. We are starting to understand that is not helpful, that dismissing distress, encouraging these behaviors, especially for somebody in a larger body, is causing a lot more harm and dismissing the existence of an eating disorder or disordered eating that could turn into an eating disorder. Also, as I've mentioned too, our implicit biases indicate an overvaluation of health or being healthy. And this kind of goes to that, that moral value of, if you are healthy or if you appear to live in a healthy body, that you're better than, that you are going to have more opportunities, and that you are going to be better, more respected, more revered. And again, our health status is not indicative of our outward presentation. And being healthy further is not indicative of our inherent value, our inherent worth. And so considering that, even on campus, considering that among colleagues, and how we exist in our bodies makes a huge difference in how we show up in our classrooms, how we show up with our students, with the world, with our faculty members. So my encouragement to you all is that we all must face and work to change these biases. We have to flip our own scripts and ask ourselves, is this helpful or is this harmful? If there is even an inkling that it's harmful, there's something that needs to be changed there. So moving on, we're kind of building on off of this information. We kind of know what eating disorders are, how they present. We're starting to understand these biases and what diet culture and diet culture mentality looks like. So how do we apply that? What do we say if we notice that somebody could be experiencing an eating disorder? And this is tricky. And from personal experience, this is something that I've crashed and burned at, and have been able to do some mending and some repair work. And there have also been moments when broached with humility and respectfully that this can be a beautiful conversation. So the National Eating Disorders Association came up with some really helpful tools for how to broach this conversation with somebody who we think could be experiencing an eating disorder or issues with their body image, etc. So first, I want you to assess the nature of your relationship. Are you their professor? Are you their colleague? Are you their friend? What is the nature of your relationship? Is this a conversation that is appropriate for you to be having with them? Is there somebody else that you might be able to talk to who may have a closer relationship with them or has more of an established rapport? You also need to assess your beliefs and assumptions about that person's body. Obviously, if you're having the concern, or if you started to see some indicators that somebody could be experiencing an eating disorder, that you might have some assumptions that could be aligned with the truth, that they actually are over exercising, or they actually are skipping meals. So just assess your beliefs and assumptions. Also, this goes back to implicit bias as well, and dig in a little bit on that. Set up a time to have a private conversation. This is not an appropriate conversation to just catch somebody walking to class, or catch somebody just pop into their office and spring it on them. Set up a time to have this conversation and make sure you're in a private area. You also might want to make a few bullet points for yourself, write a little script. And in that script, you're going to be using some I statements. Like, I have noticed you've been skipping meals. I am concerned about the amount of time you spend at the gym. I have noticed a change in your mood. It seems like you're kind of down in the dumps right now. And just say, I'm concerned. Not you're doing all of these things. And then asking all these whys. Why are you going to the gym? Why are you restricting? No, we need to dial that back, because that can imply some judgment. Avoid problem solving. Very like minimalistic or minimizing problem solving, of like, okay, we'll just eat lunch. And so just set up a plan and go to the dining hall, and you're going to eat breakfast tomorrow. Okay. And then you're going to bring a snack with you. Just eat. Or, okay, well, just stop. Can you just stop exercising so much? That's not how eating disorders work. They can't. The eating disorder is going to take that and be like, and twist it around and say, and then kind of tell the person, oh no, that there is safety in restriction. There is safety in exercise. There's safety in this, whatever this behavior is, it is that I'm using. This person doesn't know what they're talking about. Don't listen to them. And depending on how long that person has been living with their eating disorder, that can really have a stronghold on them. Next, suggest seeking professional help and offer your support in finding that help. So once you've started to talk about what you've noticed and some of your concerns, suggest, have you ever talked to a counselor about this? Or there are a few things that we can look up online. Maybe there's somebody that we can call and talk to about this who knows a little bit more about it than I do. Or maybe we can do some research. Have you talked to your loved ones about this? How about we schedule a time for you to go see the doctor and just get some labs drawn, get your vital signs taken. The National Eating Disorders Association also has an excellent list of things to do for somebody who's getting a physical exam and morbid eating disorders medical screening. And then be prepared for their reaction. Be prepared for them to react negatively to you, or to be angry, or to be defensive, or deny that there is any issue. Be prepared for that, and know how you're going to broach that. Know how maybe you say, okay, I've let you know how I feel and what I've been seeing, and just know I am here to talk to you if you ever need anything. And maybe you have to just leave it at that for the time being. And generally, somebody might be really scared. They might be angry. They might however they react. So just kind of be aware that it might not go as you hope. Again, lived experience of broaching these conversations. doesn't always go as you hope. So prepare for that and prepare for how you are going to continue to show up for that person, continue to support them, and let them know that, okay, that's fine. I'm going to back off for a second. The oh no no list. So I love watching Parks and Rec, and this is Tom Haverford, and he has the oh no no list. So things not to do, and I know it's a little misnomer here, but something to do is let them speak. Don't speak over them. Don't fill in the blanks or ask accusatory questions. Ask open-ended questions, and we in the School of Counselor Education know all about asking open-ended questions. And so that might be like, what does an average day of eating look like for you? Or what does it feel like to have somebody be having this conversation? What does that eating disorder voice sound like? What's it saying to you? Don't fill in the blanks. Be discerning and compassionate with what you're hearing, and do not be suspicious or judgmental. You might have some hunches about some things that they're experiencing or things that they're struggling with. And so you might have some suspicions or some hunches, but acting overtly suspicious or judgmental, or, it's bad to do X, it's good to do Y, those can, again, be shaming and can cut off the conversation right away. As well, be aware of your language use. This is something that I've thought about a lot and have really worked to employ into my language use. We have a lot of like diet culture-y language that's just sort of built into things that we say. The biggest one is the right fit. And I bristle at that one because that implies that there's this like right size or right way that something should fit. And I realize that that's not always the case, and that it's not all about diet culture and diet culture mentality. This is just probably a little bit of my soapbox. But I like to say something like, that seems to apply. And honestly, I learned this one from a client, and I think it's beautiful. In addition, we've all probably said you have a lot on your plate. Okay, what does that imply? That implies that it's not good to have too much on your plate, both literally and figuratively. So maybe I actually equate it to a desk. So it seems like you've got a lot on your desk. You really have a lot going on right now. And, or I think it's healthy to X, Y, and Z. Our vision of health is going to be different than pretty much everybody else's. So implying what is or is not healthy isn't necessarily our job. Another one is, let me weigh in. I want to weigh in on this conversation. Rather, let's consider maybe I'd like to contribute, or here are my thoughts. All right. You might be also asking, maybe or maybe not, you're asking this, what else can I do? Okay. These are some helpful tools that I've identified for educators specifically. So the health at every size principles are an excellent place to start. And I think this is something that we collectively as educators can incorporate into the way that we show up in the classroom with our students, with our colleagues, with ourselves. So they have 5 principles within Health at Every Size, and this is developed by the Association it was developed by Lindo Bacon, and it's copyrighted by the Association for Size Diversity and Health. So the first principle is weight inclusivity. This is the principle to accept and respect the inherent diversity of body shapes and sizes and reject the idealizing or pathologizing of specific weights. Number two, health enhancement, which is to support health policies that improve and equalize access to information and services, and personal practices that improve human well-being, include attention to individual, physical, economic, social, spiritual, emotional, and other needs. Three, provide respectful care. Acknowledge our biases and work to end weight discrimination, weight stigma, and weight bias. Four, eating for well-being. Promote flexible, individualized eating based on hunger, satiety, nutritional needs, and pleasure, rather than any externally regulated eating plan focused on weight control. One thing I also want to acknowledge is that some people do have allergies, or some people do actually have food limitations, things that they cannot eat because it could make them sick. They could be fatal. So this is not necessarily, this is different than somebody who has celiac disease, for example. And I use the example of gluten restriction. Somebody who has celiac disease cannot eat gluten without getting extremely sick. This is different. In addition, somebody who might have another underlying medical condition, this is different. And this isn't necessarily saying, hey, just, whatever, throw caution to the wind, and we're just not going to care and eat whatever you want and do whatever you want. And no, this is a much more intentional approach. It's a much more inclusive approach. And so that might include saying, hey, I'm going to make these choices for my body and what sounds accurate for what my body and my needs are, and include rest and mindful movement and exercise and a more intuitive eating practice, and work on my mental health as well. Okay, and then 5, life-enhancing movement. So support physical activities that allow people of all sizes, abilities, and interests to engage in enjoyable movement to the degree that they choose. So these health at every size principles, I think, are an excellent baseline for everybody. In addition, I encourage you to check out the Maintenance Phase podcast. Heads up that they do use explicit language, and that they crack some jokes here and there, and but they do an exceptional job at debunking diet culture and a lot of health myths. It's fascinating. So I would encourage you to check out the Maintenance Phase podcast, and even start at episode 1. The book Anti-Diet by Christy Harrison, who is a dietitian and eating disorder specialist. You also might want to look into the concepts and movements of body neutrality, body positivity, and radical self-love. These 3 movements are kind of, they can all be, I don't know if I want to say categorized together, but really focused on weight inclusivity, body acceptance, and also they have some significant differences. So they can be used in alignment, and they can be used, I think it's also really important for us to understand our relationship with these concepts. So body positivity essentially is saying, I love my body no matter what. My body is a good body no matter what. Body neutrality is saying essentially, I am going to acknowledge that my body has this function. And while I might not always love my body or love the appearance of my body, I accept that this is the body that I've been given, and I'm going to use it and do my best to respect my body every day. Radical self-love is a concept developed by Sonia Renee Taylor in terms of body love and acceptance. Radical self-love is kind of a part of sort of an offset of dialectical behavior therapy and radically open dialectical behavior therapy. Sonia Renee Taylor has taken this concept of radical self-love, and just it's basically this deep dive into I am going to intentionally love, honor, and respect my body, and because I deserve it. In addition, I've linked these two great resources from the National Eating Disorders Association. The first is the NEDA, or National Eating Disorders Association Toolkit for Educators, and it kind of applies to like elementary, secondary, high school education, but I do think it applies in higher education, as well as the Eating Disorders on Campus Guide. So these are really great tools to look through and consider as we are applying this to our school setting. So that is the conclusion of my presentation for you all. If you have any questions or want to know a little bit more, or have a desire or need for additional resources, please contact me at moneal@adams.edu. And I thank you so much for your time, and I wish you all the very, very best. Here are my references for you all to take a peek at. These are some additional great resources for you to use.